Welcome to another edition of our Focus on Facebook Live. My name is Husnain Kermalli. I'm the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Really excited and thank you all for joining us today. Each month we like to highlight a clinical department and share with you the insights and the expertise that we're able to offer to the community here in Waterbury. And this month we're actually really excited because we're focusing back on neurosurgery, and the specialty of course focuses on not just the brain but also the spine, using precision technology and state-of-the-art treatment to provide patients with the service. Really special relationship here in the Waterbury community. St. Mary's and neurosurgery, orthopedics and spine specialists called NOS, located here in town. And so together we co-manage our neurosurgery department, and I'm excited to say we're joined today by Dr. Michael O'Brien. Mike, welcome to our show.
Thank you. Thank you for having me.
And we're really proud to say, because St. Mary's is a leader, I believe, in neurosurgery here in the Waterbury area. We are, of course, gold sealed approved by the Joint Commission to provide spine surgery and spine surgery certification on that. We're continuing that process. And so you're trained in complex spine surgery, including minimally invasive procedures and open deformities. So welcome aboard.
Thank you so much. Yeah, it's great to be here.
So, you know, to right off the bat, I love to hear about the stories of physicians, sort of what brought them into medicine, their journey through their degree, and then what drove them to and excited them about a particular field. So please share with us your story.
Yeah, well, I mean, I was always interested in the brain and the nervous system in general, even before medical school. And so I worked in a lab, a microbiology lab actually, doing a lot of microsurgeries on rodents, rats and mice, and doing neuron cell culture harvesting. And through those surgeries, I got to really appreciate just the tactile dexterity that was required for some of those things. And so once I was in medical school, neurosurgery was kind of a natural fit. And then once I got exposed to the specialty through various rotations and just that clinical exposure, then I was really hooked. And so, you know, I what really draw me to, I would say, neurosurgery is the fact that it requires a lot of different disciplines. So you need to be a good critical thinker, but you also have to have that finesse and kind of, you know, very precision type of treatment, but also a problem solver too, to, you know, tailor your treatment for each patient.
Yeah, I mean, it's a remarkable field. The training itself is a little bit different than your standard sort of surgical field. There's a little bit more to neurosurgical training than you know, standard surgery. Tell us about that.
Yeah, so you know, previously, you know, neurosurgery you would do it after 1 year of a general surgery internship. Now it's 7 years of just neurosurgery, like, you know, 7-year residency. And that comes after the 4 years of medical school. And so from the very beginning, you're exposed to neurosurgical patients, and that, you know, training starts very early. And, you know, there's graduated amount of responsibility and autonomy both in the OR and with patients, managing patients. But yeah, that's it. There's a lot is involved in that, you know, over those 7 years.
You know, it's amazing because we hear about neurosurgeons, and you all are renowned, I think, across just the public persona because of that expertise, because of that training. So congratulations to you on going through that, and welcome to joining our community as well.
Thank you.
So let's talk about your specialty. Tell us a little bit about the expertise that you give, and sort of where your office and your practice is going to be geared towards for the community.
Sure. So, as you mentioned before, my practice is NOS. And, you know, we are a private practice that has this great partnership with St. Mary's for the spine program. But that being said, it lends us to being a lot of spine. So it's probably, I would say, 85 to 90% spine elective cases that come in through the office. But we still do see occasional brain tumor patients and other cranial neurosurgical issues, I would say. But a lot of it is the spine. And so, you know, my training was geared towards spine. That's kind of why I was interested in this position.
Okay.
So the last year, my residency was actually an enfolded fellowship, as you mentioned, geared at spinal disorders.
Beautiful, beautiful. Yeah. So let's talk about the spine then. 3 sections of the spine. Like normally we think the spine is just, you know, sort of neck to back.
Right.
But there are 3 very distinct sections, and each one kind of does its own little thing. So give us a little bit of insight.
Well, so I do have an interest in cervical spine disorders, and kind of, as you mentioned, of the 3.
Yeah.
I guess that's because I always tell my patients when they have neck as well as low back issues sometimes, which can go hand in hand with degenerative disorders.
Yeah.
Often we will focus on the cervical spine first. And so that the 7 bones of the cervical spine, they have this nice lordosis. We like to keep this backward curve.
Yeah.
And because the spinal cord is running through the cervical spine there, that can affect all the functions if there's degeneration there below that level. And so we will really prioritize the cervical spine first when 2 things are kind of going on. Then often we'll have to move on and perhaps treat the lumbar spine afterward, but the lumbar spine being the low back.
So it's amazing to me when I think about the spine and how involved it is, particularly when we think about the different levels. Cervical, of course, being the top level, and then you've got the thoracic sort of in the middle, sort of in the middle of the body, and then the lumbar, the lower areas. But are there new ways of doing this? Is this just the same old that we're talking about, or are you bringing, I've heard of cages, I've heard of, minimally invasive neurosurgery, I've heard of anterior approaches. So there's some different things happening apparently in neurosurgery.
So I will say, for starting with the upper section, like you said, the cervical spine, the kind of the workhorse traditional, that all neurosurgeons have been trained in is the anterior approach through the anterior triangle of the neck.
Okay.
I would say it tends to be well tolerated, that procedure, in terms of afterward pain and recovery, because it's more of a muscle splitting procedure. So you're kind of going through the natural planes of the neck as opposed to the posterior approach. And so, but each patient is different. You have to really tailor their specific pathology and anatomic variability to determine which sometimes posterior approaches is that's indicated. But and that being said, when you go posteriorly, we'll sometimes try a less invasive approach, and that can be done through tubes to minimize the amount of tissue that's being disrupted, because there's a lot more tissue on the back of the neck, like I mentioned.
Really?
So
Wow.
that sometimes can be a little bit harder in terms of pain control afterward. There's more muscle to go back through back there. So that's kind of trying to push towards less tissue disruption if you have to go that route.
Gotcha.
In terms of the cervical or the thoracic and the lumbar spine lower down, sometimes if there's a fracture or something from a trauma, you're not necessarily needing to do a huge open incision, splitting all the muscle off. We really are aiming to just stabilize the spine. And so that can be done through very small incisions. Wow. And we have, as you mentioned, technology that can make the placement of those screws very precise. And that is with a intraoperative CAT scanner called here we have at St. Mary's called the O-arm. So it looks kind of like a big donut, kind of comes in right over the patient. The patient doesn't have to, have to move the patient, takes the spin, and we see right in space where the patient's spine is located. So then when we touch instruments to the patient, it shows up on that scan.
So in the middle of their surgery, you're there, they're getting a CAT scan.
Correct.
That's showing you what's going on their spine and is helping you direct exactly where your instruments need to go. That's fascinating.
Exactly. Yep. So, we still are, and during training, we are trained in the traditional, we call open freehand screw placement, and then also using X-ray technology. So you still have to have, plan B, plan C, right? In case something isn't working or it doesn't seem right. But, the use of, it's really the gold standard at this point in spine surgery is to use, if you have the technology and you're not using it, then if there was an issue, right, you say, why wouldn't you use this technology?
So what does it give you? What does a CAT scan give you that the X-ray isn't going to give you?
So you can get all 3 planes of 3-dimensional planes, exactly. And so you can really, instead of just having, and say with an X-ray, you have to flip back and forth between one plane looking directly on top of the patient and one looking at the side of the patient.
Okay. So this is just happening all in real time.
So, they take the X-ray, or they take the CAT scan, right?
Okay.
And they do the spin, then the donut, their machine moves out, and then on screens we have an actual CAT scan image and up that's live. And so when you touch the screw or whatever, a pointer instrument, we see that instrument on all three planes of of view. And so and you verify with known anatomic landmarks to make sure that everything looks as it should.
That it's remarkable to me that we're having this kind of spatial transposition of images with what's going on live, with what you're doing, and then you've got this CAT scan image that's right there as well. So you're operating in 3 dimensions, not only with your eyes, but also with what the images are showing you as well.
Yeah, exactly.
That's fascinating. That's amazing. Well, what about outside of that? What about other spine disease?
Sure.
That's outside of the bone?
Yeah. So I would say, in terms of outside of the bone, you have the nerves, you have the spinal cord, and so that is something that's unique to neurosurgeon training as opposed to, say, an orthopedic surgeon training, because if there is issues, whether that be tumors or something where it's involving the spinal, the central nervous system,
the nerves itself,
then you have to be, we are trained to deal with those issues as well. And so, spinal oncology, I got training in that during residency, and that's, it's a common, the issue that people and patients deal with. And so as patients who are treated for cancer are living longer now with advancements for treating their primary disease, we're seeing the incidence of spinal metastasis, so cancer going to the spinal column increasing.
Gotcha.
And so we're going to have this problem is going to continue to grow, and patients need kind of a multidisciplinary approach to treating these issues.
So when we talk about those patients, then you're involved in the conversation with their oncologists, with their radiation therapists.
Correct. Yep.
The whole gamut of team is coming together again, surrounding the patient, putting the patient in the middle.
Yeah, no, exactly. And so it really needs that three-pronged, multidisciplinary approach. And we have St. Mary's is a partner with the Harold Lever Regional Cancer Center.
Yes.
It's down just here in Waterbury, and I was able to meet a few of the teams there already.
Yeah.
And so we have a collaborative approach, and they'll might reach out to me if they have a patient that has, say, a fracture called a pathologic fracture from a tumor being in the bone there. They think it may need a surgery, and sometimes I'll send them patients that I think, this hasn't caused a fracture, but they might have some bone pain from the actual tumor being there, and I think it would be more amenable to radiation treatment first.
Gotcha.
Yeah.
Gotcha. So that again, just it's an amazing advancement, as opposed to the patient just being shuttled back and forth and not getting the answers. The reality is that we're right now talking about them all together before they're even aware of a great plan, and the plan is coordinated in advance so that their life going through all the stress is already easy.
Yeah, because I mean all these different appointments, right, and coordinating that, it can be quite a bit on a patient. So, there's actually a technology that is available for patients at St. Mary's that's kind of the latest in terms of spinal oncology patients, for those that do end up needing a spine surgery, because like I said, they don't all end up needing surgery, but for the ones that do, there's this advancement. We're using carbon fiber instrumentation, and so instead of the traditional titanium implants, now there's these long polymers of carbon fiber, and it's able to improve the post-operative care, whether that be radiation afterward or surveillance imaging, because there's not the traditional artifact that you see typically with titanium on CT and MRI.
Sure.
So you can, the radiation oncologists love it because they can, they're monitoring, and then you can detect some recurrence of tumor sometimes much earlier.
Right.
And that allows them to be much more precise in their planning and the treatment of the radiation.
It continues to amaze and really make me proud of the expertise that you're able to bring to the table, but then the way that we continue to put the patient at the forefront. I mean, early, when it comes to oncology, early detection and prompt intervention is the name of the game.
Yeah.
So having this kind of carbon polymer technology, carbon fiber technology in place here just allows the patients to do that much better.
Yeah, exactly.
Which is great. So let's shift gears to talk about this gold seal of approval for Joint Commission in spine surgery. Tell us about that.
Yeah, so I mean,
to
have the Joint Commission gold seal of approval in spine care means that St. Mary's has gone through this process and they've met the requirements to even apply for to this process to be independently reviewed by an independent body, the Joint Commission, and they've come in involving a site visit and reviewed our outcomes and say that our outcomes meet the standards to deliver high quality and safe spine care.
Right.
And it's no small feat to not every hospital program achieves that. And so when you see that gold seal, that means that our program has met those standards, and they have to be measured. So there's performance measures. You have to track everything from the preoperative care to the actual OR efficiency, and then postoperative care, all of that.
And this is again our focus on keeping the patient's high quality care at the forefront. That we're open to say, hey, reviewer, come back in. I take a look at it as almost like going back to grade school, elementary, or high school, and saying, hey, let's do a pre-calculus test. But rather than the teacher assigning it to us, we're going to the teacher and saying, hey, you come and give us a test. We're ready for this. We recognize our program is excellent, and we want to have that recognition because we're benefited by having such great teams on the floors, such great team that coordinates with the patient, and then great providers that are able to sort of round that all out.
Yeah.
So we're really proud of that.
Yeah.
And thank you for being a part of it.
Yes, of course.
It truly is one of those partnerships, because in our partnership, we look at these quality metrics as well, just internally. And I think that's what makes this agreement and arrangement of co-managing the neurosurgical division. So it's not just the hospital that's involved, but our neurosurgical partners as well. And we focus on how long the patient stays in the hospital, making sure that's efficient, making sure that your time in this operating room isn't so long, that it's appropriate, that we're getting patients through the system. And so I continue to see benefits of being partners in this journey.
I agree, and I think actually even your push to get everyone up to speed with the new Epic, the new health operating system. Yeah, exactly. I mean, I've already noticed a difference in that too. I mean, it's pretty amazing that you can get a notification on your phone, or my watch saying patient has entered the room. Yeah. So like the patient is in the room, and you're going to be there that much sooner, right? So it's just all about efficiency and utilizing the time.
That transition, and for those who aren't aware, we've changed our electronic medical record. We had Epic before, but I think we've got the Epic 2.0 now. Yep. It allows so much better communication. I mean, there's a secure chat embedded. So now if you and I need to communicate about a patient, it's embedded. That communication is directed, and it's connected to their chart. So we're not missing or getting lost in which patient we're talking about, because we might have a long list of patients that we're working together. That kind of notifications back and forth to the providers as well. And then just more functionality in the program itself. So we're really proud of it. And thank you for going through the training. It was quite monumental, but we had, all of our providers went through it. The good news, it was Epic to Epic conversion. So it was less learning, but more just becoming accustomed to what the new one is going to bring, which was great. And thank you again for going through all of that. So one thing we like to do is that last nugget that you want to share with the audience on something that you see as exciting in the neurosurgical world or otherwise from your perspective.
I would just say that between the different technologies we talked about today, patients should, and providers too, that treat patients with spine issues, should know that they don't have to travel far outside of Waterbury to get comprehensive spine care. And that care is being monitored, tracked, the outcomes are being tracked, and it meets that standard. And so patients should be confident knowing that.
And that's a great reminder. Dr. O'Brien here is ready to see you from a spinal surgery perspective, and it's able to happen right in their own backyard. Understanding we've also got partnerships with the Harold Lieber Cancer Center, a radiation oncologist if that's an issue. But it's that whole patient, keeping the patient in the center. We care about them all the way around. And we love that. So thank you for that as well.
Yeah.
Now, one thing, because it's a new year, so happy New Year's to everyone. But one thing we wanted to start, and you get to be our first. And I'm shamelessly using this from something I've seen before, which I think is fabulous, is I'm going to ask you to ask a question to our next provider that's going to come on board. Something that intrigues you. And you don't know who that person, I don't think anybody knows who that person is just yet, but you get to ask them a question ahead of time. And then we'll record that and make sure that gets asked, and we'll continue that tradition moving forward this year. So a question for the next one coming on board.
Sure. I guess I would say, what's one thing that you've recently learned from a colleague or someone that you work closely with that you want to implement this year to try and improve your practice and improve the outcomes of your patients?
I love that. So we're not going to ask you that question. We're going to ask the next provider that question. But thank you all very much, and thank you, Dr. O'Brien, for spending some time with us, and look forward to continuing our partnership together.
Thank you for having me.
Have a great day.
You too.
Thank you so much. See you all next time.